With respect to liability, organizations are responsible for their own actions, and we tried to keep it very simple from that aspect. And applicable law. Applicable law is the law in the state in which you operate, and federal law. And if you're a federal agency, it's federal law. Tried to keep it very simple. It seems simple, but if you read the agreement, it may not appear to be as simple. There has been a coordinating committee established and a technology committee, a technical board, to work on issues like breach notification, resolving disputes, onboarding, and working with membership. If there is a participant in the NHIN who violates the agreement, any of the provisions, it becomes a risk to others. The coordinating committee may suspend their ability to communicate using the NHIN. That's a pretty serious matter, but one that is necessary to instill confidence in the system. That's all I have for now, and be happy to respond to a question or two.
Thank you, Holt. Are there any questions from the group? Clarifying?
I'll hold
Yeah.
Okay. Bill Holt? Okay. Well, then we'll move on to Phil Renner from the NCQA, who will speak with us about their efforts regarding integrity, accuracy, and authenticity.
Okay, and I'm going to take a slightly different tack. I do measurement. I think about measurement, so I'm going to come at this less from a clinical generating the information and more from a how do we rely on data generated out of clinical care processes to be able to do performance measurement. And so what I want to do is really rely on insights that we've gained through data collection, supporting a number of data collection efforts that NCQA does through EHRs and others. What we do is we collect data, do performance and quality measurement. Been doing this since about 1990, and doing this to try to enable and ensure transparency and accountability through measurement. We have about 2/3 of the health plans in the United States are accredited. It's about 75% of HMO lives. Each of those health plans has to submit HEDIS data to us. We also collect data from physicians and physician groups through our recognition programs. And I'm going to talk a little bit about, in the next couple of slides, about how we validate and audit those programs, because it might give us some insight into how we want to do this through electronic health records. So actually, I'll skip this slide just in the interest of time. So talk a little bit about our, for example, our diabetes recognition program. We have a number of measures. There's about 10 measures in here, all NQF endorsed, that assess critical aspects of care for people with diabetes. These measures are used for pay for performance and pay for reporting through PQRI, Bridges to Excellence, and other health plan programs. It can be submitted either through paper chart abstraction or through submission directly out of electronic health records. And because it's used in pay for performance programs, the bar is fairly high for making sure that we have accurate and valid information. So we're receiving submissions for the diabetes recognition program from a number of EHR vendors, including GE, Centricity, Kaiser Permanente's Epic installation, and others. What we use is an XML schema that we developed in order to facilitate this submission. It's also being used to then we pass this information along to CMS to support PQRI reporting, as do a number of similar registries. One of the things we've learned is that Despite the electronic systems, edit checks and automated checks, it still requires a significant amount of user support, helping to interpret how do we do this, and then further validation upon submission of the data. So just having the infrastructure in place doesn't always mean that we're getting accurate and complete data. Health plan HEDIS that we get from managed care organizations, this information, this data undergoes a multi-level validation approach. First, we provide detailed specifications, very clear about algorithms, codes, how do you select people, what counts, what doesn't. We certify software vendors, so if a health plan uses an outside vendor to calculate their HEDIS rates, we actually go in and certify those vendors to make sure that their systems accurately and completely calculate the performance measure rates so that we know that we're getting good data. We also certify auditors. We put them through an NCQA auditor certification program so that when they go out to the health plans, assess, are they using the right methods and approaches, again, to make sure that the data is accurate and complete, since so many health plans, purchasers, regulators, et cetera, are using this HEDIS data. We want to make sure that what they're getting is accurate and complete and reliable. So what we do through the validation, through the audit program, is make sure that both the structures and the processes are there to make sure that the data that is submitted is complete and accurate. So what does this tell us for, what's this tell us for this future over the next couple of years of gathering and using EHR-based data for measurement? So what the slide I have here is essentially a assumed data flow process that we're thinking about. How is this going to possibly work, whether this is measures for meaningful use, whether it's for an HIE or a payer program. The measures are developed and endorsed by NCQA or AMA or others, endorsed through the NQF process. Standards have been developed so that the measures can be, and I'll talk a little bit about this, but so the measures can then be imported into the EHRs a little bit more seamlessly. And then the measure goes into the EHR, and then it's linked up to a reporting system, again, whether this is PQRI, meaningful use, or something similar. And then there's sort of an implied arrow at the end that also has this input of clinical data. So clinical processes have happened, feed into this reporting system, and then the data is reported out for the purpose of performance measurement. We're assuming, and I think we're all hoping, that the measurement that's going to be done in the future is going to be done with automated performance measurement collection, not manual review. The scale of having physicians and clinicians everybody go into their records and do this by paper is just, or paper or pulling it out of their EHRs and doing it sort of manually is not going to work. So we need a way that we can have this flow automatically and automated in a valid way. So what is that? So what are the, sort of the NCQA learnings that we've had in our programs? How's that going to inform some of this? Okay, so first we need to think about how do we standardize the measures. NCQA collaborated with the AMA and the EHRA to develop what we were calling the electronic quality measures format, which was a XML-based schema for representing a performance measure. NQF funded and led the submission, enhancement and submission of that format through as an HL7 standard. So it was recently approved as a draft standard for testing use. And so we're beginning to put measures into that format. and the first thing we need to do is retool the measures into the it's called the health quality measure format. I think Floyd Eisenberg has been here before to speak about the quality data set and how the NQF is taking the measures, sort of breaking down the data elements, the value sets and such, so that these can be standardized. And then in the end, this step, standardizing the measures, getting them into a format that is EHR readable rather than human readable, will help disambiguate or at least minimize the amount of ambiguity that's in the sort of current paper text specifications that we have. So I think that's the first step we need to think about. So the second step is around standardizing the capabilities of the EHRs to be able to support performance measurement. So can they capture the data that we're going to need? So CCHIT is going to be certifying the functionality. They've put forward these preliminary ARA 2011 certification standards that cross-link existing functionalities and capabilities to what will likely be needed in order to support reporting for meaningful use. So examples are, is there a functionality to maintain a problem list, a medication list, et cetera? You all are probably very familiar with that. I think the second thing, though, that comes in terms of standardizing the capabilities is also being sure that we've validated the measure calculation, that the EHR or the entity that the data is being submitted to will calculate the measure correctly. So that the data comes out of the EHR. We do this as part of our software certification program, where we have standardized test decks of a population of patients, run that through the system. We know what the answer out of that population ought to be, see what result comes out at the end as a way of validating, yes, it's pulling down, using, and calculating the results correctly. Finally, we're looking at how do you standardize the reporting out. The quality reporting data architecture provides a good tool for this, and it allows the system to either submit the results, a numerator, denominator, and a rate, or individual patient level meets the numerator, meets the denominator, or the third level is submitting detailed patient level data. What are the blood pressure readings, so that an HIE, for example, could combine that with other external information, or a registry could compute that the measure performance rates using that data combined with others. But again, I think we're going to need a standardized ways to pass this information, again, so that we can make sure that we've set up ways to validate the data as it's passed through. And speaking of validating the data, the other two pieces I've talked about, I'm much more comfortable that we have systems in place to make sure that this stuff is going to work. What some of my colleagues talked about previously, and what I'm going to talk about on this slide is what makes me a little bit more nervous. It's kind of obvious, but it's probably worth restating. The measures are only going to be as good as the data that underlies those measures and goes into this data calculation system. And what we've seen in a lot of the research that we've done into building measures out of electronic health records is that the workflow that happens within the practice can affect whether or not we can do automated data measurement. She's nodding her head and sees this probably on a daily basis.